That's perfect. Thanks.
Okay. Sorry about that. Thanks, everybody. Ken and Mark and Tommy, thank you. What I'm doing this morning is I'm going to talk to you about my experience with the NFL and the high ankle sprain effort and our attempts to mitigate injury burden. There are no conflicts of interest here, except I would tell you the very final one, the NFL Players Association, is what kills us every time we try to do anything, because they constrict the kind of information that we get and that we can use in trying to do research for the NFL. So just a little background history as to why I'm where I am. And in 2005, I was asked to be a member of the National Football League Injury Committee as a non-affiliated person, probably because of the concussion issues that permeated certain the NFL, and they wanted some transparency. And so I became a member of this committee and traveled to New York on a regular basis. This is a younger picture of Roger Goodell, but he was not as stressed 15 years ago when I came on this committee. And then in 2009, I became a co-chair of the committee, and it's made up of members, trainers, equipment managers, and NFL personnel. And we really try to isolate injuries and to really see what we can do to mitigate them. We meet a couple times a year in NFL offices and also in Indy at the Combine each year. Just as a background, the NFL is an association of 32 individual teams. They're individual corporations. So they're like 32 orthopedic surgeons in a room. Nobody can really agree on anything, and they fight all the time. But theirs is all about money. And the owners run the business through various committees, and Goodell really serves just at their pleasure. Now, there are millions of dollars of research available. It's just trying to get a hold of them. And it's sort of mind-boggling when you think about it. But then if you think of like the number one draft choice this year will get $180 million for 4 years, and you think, well, a few $1 million to throw at trying to reduce injury rates would be really not that big a deal for putting it on the table. So our committee interfaces with Goodell and the NFL staff, the competition committee, which they're the ones who changed the concussion sort of discussion by really reducing kickoffs and punt returns. And of course, the Players Association that continues to plague us with what we do. Just as an aside, we meet in Park Avenue in a rather indiscreet place. You need these special IDs just to come up to get in the elevator. There's unbelievable scrutiny. And we sometimes talk about the fact that if there is a terrorist attack in the United States, this would be the major knockoff, because think of what it would do to all of us who care about football and things like that. So you can't believe getting into this office. It's much different than getting on an airplane. Anyway, the most often question I get asked is, how did I get this job? Because it is kind of an oxymoron. I was raised in Boise, and the whole reason I'm there is because my father was the second orthopedist in Idaho, and Mark Meyerson's the only person who actually met my dad in this group here today. But he was a friend of Matt Clayton, who came from Denver. It's one of the reasons that I went home to Idaho. I was raised in Boise and was in the department for 40 years and ran several organizations. And so as I say in March Madness, it's probably the body of work that gets you into where you are with things. And that's sort of why I got this job. But if you look at a map of the United States, and I want you to look at this, here you are in Denver watching the show. There's Seattle, and there's San Francisco, and and Oakland. And here's this huge void in America. And actually, if you look at the distance from Boise to all these places, we were the most isolated place, obviously. And so if you wanted to get a transparent person that has no hooks from the NFL, Boise was a pretty good place to pick somebody from. So anyway, with that in mind, we've been working on these things for a long time. And this was one of the publications in the American Journal of Sports Medicine. We talked about the incidence of lower extremity injury in the NFL, and it's huge. It's absolutely huge. If you look at 10,000 player days in these 3 years of injuries, excuse me, the knee's high with ACLs and so forth, but the ankle is right there with lateral ankle sprains that are much more common, but high ankle sprains that really cost you more days. So the risk of a lower extremity injury to these players each year is about 40%. They may not be big injuries, but they are injuries nonetheless. So I want to talk a little bit about injury burden because This is what injury burden is: the frequency of the injury and the lost time per injury. So if you look down here at the bottom, you can see that under high ankle sprain, there are fewer injuries than there are lateral ankle sprains. But if you look at time lost, the high ankle sprain really loses a lot more time. So this is then a quotient or a number that is the injury burden. I don't look at it just as this number itself. I think of not necessarily the time lost, but physical deterioration, pain of the player, reduced performance, and bad things that happen like arthritis later in life. Now, the NFL projects that this costs them $500 million a year. And I can say that that's probably a conservative estimate when you think of a high-priced player that's out, and how much money it costs them per game. It's probably a conservative estimate. So there's been this effort by the NFL to invest about $30 million to attempt to achieve injury reduction through the projects such as this. I'll give you an idea of what we've been doing. Now you can see that for concussions, they changed equipment. This year, the players can no longer pick their helmet. They're going to be forced to use helmets that the NFL really authorizes. That's a change. There's also changes in just kickoffs and punts and things like that. And the incidence of concussions has really decreased substantially, in spite of the fact we're looking closer at it and probably calling out more concussions. So the question was, could we do the same thing with high ankle sprains? So we brought in the people from Detroit, from UVA, who did a lot of the Detroit studies on crashing cars into walls and seeing what they did. Those weren't resuscitantes; those were cadavers that they would smash up, and then they'd see what happened. So they have a lot of experience with cadavers, and so we designed this intervention prevention type of strategy on the circumstances of the injury. And while we can't change the circumstances, we don't even know what they were when we started this study. In other words, were they direct injuries, indirect injuries, or non-contact injuries? And for example, a brace might work better for a non-contact injury than for a direct injury. So one of Bob Anderson, my cohorts, thought was we need to define what a high ankle sprain is, and we need to see how it happens. So if you look at this, if you look at the direct contact, that's another player loads the ankle. He falls or rolls on your ankle. Now, indirect contact, you might be trying to tackle somebody from the waist and you load your ankle, but it's not something that no one really fell on this ankle. And then a non-contact is a push-off and no other players involved. And so we then had the people from UVA and their video department analyze every ankle sprain that occurred in the NFL over our period of study, which was an inordinate amount of work when you realize with the videos that go on, there are probably 8 or so different views of these injuries, and they would sort through until they found the classic view that they could then determine, was this just a lateral ankle sprain? Was it a external rotation injury or a high ankle sprain? So most of our injuries occur in external rotation. Now, some people were out for a long, long period of time, and so we included them in the study just because we thought they might have had an external rotation component. But it's a very different injury, a high ankle sprain, from the inversion injury you see in just a run-of-the-mill ankle sprain. Now, the position of the foot makes a difference as well. The foot's already in inversion, and then it externally rotates it, and it's engaged in the turf. I have to tell you, the surface and shoe interface is a whole nother talk that takes 2 or 3 hours, because we've done so much in this area. There are now rules for keeping your turf up, how you maintenance, like if there's a huge concert the night before on the turf, they have to get in there and prep the turf so it's ready for the game the next day. If you're tackled, you don't want to be tackled on the Broncos emblem in the middle of the field. You don't want to be tackled in the end zone in general, because they're all painted and they're much, much harder than the regular turf. And if you'd like to be tackled, it'd be nice to be tackled outside the hash marks, because most of the action occurs on the hash marks, between the hash marks, where it's really hard surfaces. But nonetheless, external rotation is a mechanism, and the position of the foot can make a difference. Now, I'm going to show you some movies here, and I'm going to show this injury, and these are all right ankle injuries. I've tried to make it simple for you to see, and the blackout is sort of for the Players Association. You saw this right ankle just get totally twisted. And it's sort of a farce because you can figure out who this was, but the point is the Players Association would like us not to even call out individual players. This was a direct contact injury. I'm going to play it again for you to see. They're all going to be the right ankle, and so you watch this Cardinal's right ankle. There he is. He's externally rotated, neutrally flexed or everted ankle, and then sometimes they dorsiflex as well. That's a bad injury, as you can see. Now, here's a less common injury. Watch not the Saints player, but the Eagles player. It's the right ankle here, and this is a non-contact injury, and that's his right ankle. And now he's getting his injury now, and so he's dorsiflexed and everted in an external rotation. This is watch the Saints player right. This ain't right ankle now. That's a lateral ankle sprain there. He probably tweaked both his ATFL and a CFL. It's a plantar flexion injury, and that's way more common. That's obviously a non-contact injury. So how do the video reviews findings align with our knowledge of cadaver studies? Well, our group, again from UVA, did some experimental studies to look at this and to look at the injury pattern to help us define what a high ankle sprain is. So this is the cadavers, and this is not easy stuff. Our cadavers are not 80-year-old housewives that passed away. They're in general 20 to 25-year-old males who were driving their pickup truck and crashed into something and died. So we wanted to have the same kind of bony structure that we would have, or be at least close to these NFL players. So I want you don't really see much when we run the video of the cadaver, but I want you to watch the tibia and fibula here. And first you saw the ATFL go, and then the fibula went right there. Now we're going to watch it again. Here we're stressing it. Here we're stressing it. They didn't always break, but you see it does there, but then we see it spread. Now, if you look at our model here, what happens first is you see an AITFL rupture and then the fibula fracture. So let's see this. Let's watch it one more time. And now it spreads there. That's AITFL, and then that's the fibula fracture. So we know it happens in a pattern here. Now this is even more informative because I want you to watch how this injury propagates. And what's going to happen is the AITFL tears, then the superficial deltoid tears. And what we believe is it's sort of a circumferential injury that occurs. 1, 2, and then it goes posterior and rips or fractures, either rips the posterior structures or breaks the fibula. Now watch here. It's very quick though. It goes 1, 2. There the AITFL goes, then the superficial deltoid goes, then the interosseous membrane goes. So we've used the computer animation to really show this, how the AITFL loads, then the deltoid ruptures as well, and then the interosseous membrane goes as well. So with our experimental observations, I'm not going to get into this in detail, but we know that the plantar flex injury, there's a lower tolerance for collaterals below the AITFL. So that's why we get the ATFL and CFL. The neutral position has the lowest tolerance to injury. And then in a dorsiflex position, there's increasing likelihood of an AITFL injury due to external rotation. And as we said, the superficial deltoid in general precedes the syndesmotic injury. Now we felt that we should start with defining the constellation of injury pattern. And so we had musculoskeletal radiologists join us. Bob had one and I had one in Boise, and we reviewed the radiographs and the MRIs. And we started out with the electronic medical records, which all the teams use, and it had to be coded for a high ankle sprain. And then, of course, we used the NFL films to show that these were indeed external rotation injuries. Unfortunately, not all of the teams comply because you've got 32 different teams and doctors and the way that they do things, but they both needed x-rays and MRIs to be included in the study. But what we really didn't know when these people get surgery, whether they're in college or if they're in the NFL, is what's the constellation of injury? Do they all have AITFLs or PITFLs? How common were the lateral ankle ligaments, the interosseous membrane, and other structures, and how the ankle got injured as well. So if you're going to design an injury prevention program, we need to know what the circumstances are, and maybe we can and maybe we can't change the circumstances, like the concussion issue. A brace probably would work better for non-contact injury, but if a 300-pound lineman falls on your ankle, nothing may help you as far as that's concerned. So we started with roughly 500 injuries that were coded this way, or that had lengthy recovery times after some kind of ankle sprain, and we reviewed those. We ended up with qualifying about, excuse me, 150 cases, and we divided half of those between Boise and Green Bay. Now, we were completely blinded to the players, the position, and whether they had surgery. We were just required to call out all the MRI abnormalities. And I'm going to just sort of segue here to a wonderful study that was run by Tom Clanton at Stedman. And this was just an anatomical study that shows the anatomy of the structures we're talking about. The AITFL, and you see the PITFL here, and then we have the syndesmosis ligaments. And this is the whole point of this so-called cartilage or joint in this area, that if you're going to put a tightrope or a screw across, it's better to be above this area than to be through this cartilaginous surface in this area right here. So the criteria were they had to have the following: AITFL, PITFL, or IO injury. We wanted to see all these other things that might occur, such as the lower lateral ligaments, syndesmosis spread, fracture, medial ankle widening, tendon injury, and OCD. We had no idea. Now, I can't give you the numbers. We do have these numbers now. When I wrote this a few months ago, those numbers were not available, but I can't give those numbers out because of the Players Association. But I've watched this enough that I have my sense, and I have the right to speak on this, whether I have exact numbers or not. Likewise, with surgery, we never really were told who got surgery. And some people got surgery because maybe they wanted to get them back sooner with just a simple AITFL injury. Some had a Maisonneuve type complex and were not going to return for a year. And we don't know who did well, but we will be able to track those as well. One interesting thing that we did observe was that there were very few bony injuries. In other words, there were very few fractured medial malleoli or fibula, Weber C's. These were almost all ligamentous injuries. It was very rare to have this type of injury, even with the direct contact. So why the paucity of bony injuries? Well, we sort of conclude, and this is just a conclusion, not based on anything but our notion, that this group of elite athletes probably have strong, big bones that are resistant to fracture. They're not like the little housewife that slips and twists her ankle. The muscle tone and quality may be protective of fracture. And again, these aren't high velocity car crashes like you see off your freeway. Their torque injuries tend to injure soft tissues in the field cleat interaction. And of course, the question is, when is the ankle unstable, and how many underwent surgery? And probably about a fourth we have a notion of, or a third underwent surgery. So when we went through these MRIs, Bob and I and our radiologist, the AITFL was very common in almost every case. The PITFL, meaning it's circled around, was almost half of the AITFL injuries with that. So with these high ankle sprains. The interosseous membrane, it always associated with an AITFL, but sometimes it just had sort of a sprain and had fluid and didn't have a direct tear. What we thought was, or what we were surprised was, there were a bunch of ATFLs and CFL injuries with this. We just don't know if these were older, like a few weeks old, or if they were a brand new injury. In the lab, the calcaneofibular ligament was injured in 50%, and the ATFL injury was injured in a third of those. So, we have some questions we can't answer. What we were shocked about, though, was the number of contusions of the joint surfaces and also the osteochondritic lesions of the talus. So this is a player that obviously there's no fracture, but everything's torn. As we went through this, 23% of the players didn't have x-rays. In other words, they came out of the game. They They might have had one picture in the locker room, and then they went straight to an MRI, probably because of their agents and things like that. And then 28% of them had x-rays but didn't have an MRI. These are all elite players. I'm not a big MRIer for everybody in the book, but these people are high-priced players, and I'm sort of surprised from just a defensive standpoint that the doctors didn't get MRIs on these players. So we lost a number of them because of the lack of complete imaging. What I would tell you is these people are out for a long time, average 40 to 50 days or 60 days. And one of the reasons why is the concomitant injuries that occur are stunning. There's posterior tibial tendon injuries. They were occasional, we saw. Peroneal tendon injuries, occasional. Lateral ligament injuries as well, although some may be pre-existing. Also, OCDs and talar contusions were extremely common, and they seem to be associated, as you might expect, with more severe injuries and with increased ligament instability. So we came out with some recommendations for the radiologists, whether they're in Seattle or Denver or Washington, D.C. And you might say, well, that's pretty standard anyway, but somebody had to write this down. We're going to put this in some sports journal just to make it clear that this is what we think. It's not what they have to do, but we think that you want to obviously get an AP mortise and lateral views. Just your locker room single x-ray to see if they have a fibula fracture is not enough. And then I think AP stress views, Tom Clanton talked about this for years, but this is the way that we suggest doing it, seeing if there's a clear space widening of over 5.3 millimeters, widening of the medial ankle mortise of over 4.5 millimeters is indicative of a deltoid rupture. So, and then attention to proximal mid-calf pain, look for proximal fibula fracture. And that was just what we threw out there. This is actually a picture of Tom in his younger ages stressing an ankle, which I thought I would throw in here. We didn't do any dynamic stresses at all because we didn't do the treatment of these people, but it would have been very nice to have this. And that will obviously expose in your practice a purely ligamentous injury. Now, this is what we're throwing out to the radiologist. And our radiologist went through this, and I don't expect you to write this down or memorize this by any means, but you get like 1,000 different shots or slices, and what's going to really be the money slices and so forth. Well, you can see the axial T1s and FST2s are going to help you for your lateral ligaments, for the PITFL, and for the deltoid. The oblique axial FST2 is going to help you for the AITFL and your tendons as well. It's the coronal and sagittal, the real straightforward ones. They're going to show you a talar OCL, and the spring ligament and deltoid also on your coronal T1s and T2s. But again, I must tell you, some of these MRIs were marginal and very tough for us to read. Again, I told you we didn't see many of these syndesmosis disruptions, and we saw very few postoperative x-rays as well. So for all teams, we're recommending that they get standard routine x-rays and MRIs and stress films, whether they will or not is their call. These are the radiologist definitions, and you're fairly familiar with these, but a grade 1 just shows soft tissue edema adjacent to the normal ligament. Grade 2 is a partial tear, and then grade 3 is a full thickness tear, and sometimes you'll see wavy retraction of the fibers. Now, what I'm going to do now is go through just some cuts here to show you some things that we see, just because of the Players Association and so forth. These are not NFL players. We substituted Boise State players, Oregon players, and people who we can use anonymously, but not use an NFL player so that we can't be called on the carpet for this. But this is an acute lateral ligament or ATFL injury. It's an axial FST2, and there's a full thickness grade 3 tear of the ATFL with retraction of the talar insertion. This is a syndesmosis injury, and here you see a normal AITFL right here, and then this is an axial T2, and there's a full thickness retraction of the ATFL. There's hemorrhage, as you can see, in the flexor hallucis longus sheath, which will require a longer recovery, and this is an axial and coronal T1. Now, this is a chronic injury, and you can just see a chronic injury from as a resident in training. There's no soft tissue edema all the way around this. So this is an old injury that we're looking at right here. It doesn't have all this bubbly, fat sort of injury with edema. This is an axial T1. This is AITFL, and it's a chronic AITFL injury, a thickened ligament in this region. And then you see some scarring of the PITFL as well. And we would see these, and we're trying to call out what's new and what's old. Now, this is an acute AITFL and PITFL in an axial FS. They're partial tears, and there's also a talar contusion. And you see a lot of soft tissue edema here and here, so you know that's an acute sprain as well. Now, here's an acute posterior injury, a partial tear in the transverse tibiofibular ligament. You see right here, which is lower than the PITFL. And so this isn't a perfect sequence for the PITFL. Usually you need 2 or 3 planes of imaging because of the oblique orientation of many of these ligaments, but you can see that there's injury to the ligament as well. These are syndesmosis injuries. You can see this is acute because of all the soft tissue, and we see a partial tear in the interosseous ligament. This is what you would see here with edema in the interosseous ligament here and here. This is also a syndesmosis injury. Now, this is a chronic interosseous tear. There's no edema in the soft tissue, but you can see the injury here and the injury here. So this player indeed had an injury, but this is not an acute situation. This is more an acute situation with a axial FS showing an interosseous ligament tear and probably spreading here. This is a full thickness tear of the AITFL and the PITFL, which would be pretty indicative of an unstable ankle with that, and it'll probably pair in with an interosseous tear, maybe even a superficial deltoid. The deltoid is a tough number to look at. It's really difficult. This is a deep deltoid tear with this sort of opaque nature of the tissue here in the deltoid, and this is a acute partial tear of the deep deltoid. Now, it's not the deep deltoid that we typically get in a high ankle sprain. It's a superficial deltoid that, when not fixed, and you fix the lateral ligaments, you sometimes end up with instability later on down the road. For the superficial deltoid, this ties in with the spring ligament, the tibionavicular ligament, and blending in the superior medial part of the spring ligament. And we see here partial tear of the superficial deltoid. And then again, this is the junction of the tibial-calcaneal and tibial spring ligament near the sustentaculum talus. Tendon injuries, again, and I'm just giving you this potpourri of scans to show you what you may need. And you may not be the best MRI reader in the world, and I'm certainly not. I sit there with my MSK radiologist and I go, is that really torn? He goes, yes, it is. And I go, okay. So, I mean, don't rely on yourself. Make the guy tell you what he thinks as well, but try to get better at this. This is a tendon injury, and you can see here, there's a longitudinal split tear in the posterior tibial tendon, and we saw these in these players. And think of these, this is a posterior tibial split as well. Think of somebody with a high ankle sprain and then gets a posterior tib injury or peroneal injury. They're going to be a long time coming back if they come back at all. And it's in other words, what we're seeing here is a constellation of injuries that's very much more than just, say, an AITFL injury. Bone injury, well, this obviously is an old OCD or OCL. This is a bad ankle here. Here's a more maybe acute injury with just a smaller OCL in this region as well with subchondral edema, but there's arthritis of the ankle joint as well. Here is an OCL of the lateral talar dome. We saw lots of these, and this pretends these players can probably play for 3 or 4 or 5 years, but where they're headed is going to be some type of ankle reconstructive surgery in the future. So when's an ankle unstable? Well, obviously that is, but something like this tells me that it probably started laterally, or there's a high probability it started laterally with the AITFL spiral around to the medial ankle, tore something in the deltoid region, and then finally went posteriorly. So I'm very suspicious if you just have this and don't have a medial malleolar fracture, you still have an unstable ankle. So where do we go from here? Well, it's not a simple situation. There's a lot more injury than just the interosseous ligament and the fibula. And you can see this one was fixed, but not really fixed very well. And we see a spread afterwards. Likewise, we see situations where somebody has a couple of tie ropes placed and they're returned to action as quickly as possible, and then they have an injury someplace else, like what happened with Tua with Alabama, where he came back quickly and had a dislocated hip, probably, and that's just my guess, that he was detuned and had that injury because of his quick return to play. I'm not saying we can't get these players back quickly, because we can, but we have to be cognizant of the risk factors involved. As far as lessons learned, well, we didn't do any dynamic studies or physical exams, and MRIs don't tell the whole story. They're not prognostic. And the MRI doesn't show the superficial deltoid well. We miss these, but there's a constellation of injuries here, and the mechanism is consistent, but the presentation is not. There's so much we don't know. In the early days, many years ago when I was in practice, we actually were influenced by a fellow from Boston named Isidore Yablon, who just said, we need to fix the lateral ankle and that will be enough. I always went medially and fixed the medial ankle, and I just didn't talk about it because I think I was sort of a very rare person doing this and an outcast. And now the pendulum's kind of changing, and we're going back to saying it doesn't take much to go in, look at the medial joint space, maybe scope the ankle, of course, first, then look at the medial ankle joint and fix a superficial deltoid if it's torn, and you may do the person a great service. Here's where the rubber meets the road. The direct number of percentages, indirect and non-contact injuries in our ankle study were 70, 20, and 10. So here's the problem that we went back to the commissioner and said, look, this is a tough game. It's brutal. And most of these people, you're not going to keep them from tackling. And so the 70% is not going to probably go down. This is not like concussions where there's some low-hanging fruit as well. We believe that possibly there's some type of tackling techniques that we can change, but in general, this is an injury that's going to keep happening. We've changed dramatically the turf itself and how we treat it and what kind of turf people get, and likewise, the cleat interaction has been a continuing story of our battles with Adidas and Nike, who really claim that shoes are just apparel. They're not really a safety factor. And we believe the opposite, that they're cleat patterns and the depth of cleats that make a huge difference in when this shoe and foot interacts with the surface, and then it doesn't give way when they tackle or get tackled. There are twice as many low ankle sprains on synthetic turf, and that tells you something. And that's what computer modeling has helped us. So for you in practice, you won't see nearly as many high ankle sprains as you'll see low ankle sprains or just run-of-the-mill ankle sprains. But when somebody, and not every one of these people needs an MRI for sure, they all need x-rays. I honestly believe the Ottawa criteria, that's just great if you're in some kind of management system for decreasing costs. But if I have an ankle like this, I'd like a full set of x-rays, thank you. And I want to see what the magnitude of the injury is. When you see something like this, I think you're probably going to get an MRI as well after you get routine x-rays. But it's not a simple situation, as I told you. The injury pattern, the player's cleat is engaged in the forefoot and externally rotated. Here's the offensive lineman, defensive lineman, they are definitely engaged in the turf, and they are the ones who really get a bulk of these injuries in the trenches, and then they fall down and have an injury as well. So I think that when you look at what happened here with all the OCDs and tendon injuries and contusions, there were 86 different pathologic patterns in the 110 injuries that we scanned. That means, like, you might have an AITFL, but then you had a talar contusion or posterior tib rupture. So it's not surprising these people are out for a long time, but you just got to know what you're treating. Even without a fracture, there may be substantial ligament injuries. I think that we believe the electronic medical records could be a little more helpful on our injuries. We're now coding with a RFID code all the shoes that they wear, and these guys change them at halftime, so it's a moving target, but we want to know what shoes they're wearing and what cleat patterns they're wearing. The other problem is some of these guys go out to a local store because they can buy the old shoes out there that they like, old cleats that they like, and they don't have an RFID little tag in them like the helmets do. So it's really tough to code these players when there's a scanner as they walk out onto the field, and it scans their helmet and it scans their pads and it scans their shoes as well. But we're tightening the noose on all these factors to try to learn more, because we have actually from year to year looked at different cleat patterns. We test them on artificial and real turf, and we see which ones don't give way as much. They have that they could really induce more torque, and because of that, we put a big cross through them and said, just like if there's a car that's unsafe, you say it's unsafe to drive. We tell the players in the locker room, these are 6 models that are unsafe to wear. Whether they do or not is their choice, but it's sort of buyer beware. And I think we could have better imaging of our players as well. We won't lose as many. So where do we go from here? Well, again, a lot of these are contact injuries. Bracing may help the lineman. One of the things Bob brings up is, you can inject many places. You can inject an AC joint, and you probably can inject the interosseous membrane. That's up to you, but I mean, it's not like injecting an ankle joint itself. I do believe the turf cleat interface holds promise of injury reduction. It's a battle we continue to fight. It's sort of a love-hate relationship. Nike gives the NFL millions and millions of dollars, but yet we're asking Nike to be a player here, since they provide about 85 or 90% of the shoes. But I can tell you the foot was fixed in 100% of these injuries to the ground and to the surface itself. Where's the safest surface to play on? It's a frozen, muddy Soldier Field. That's where you want to play, because you get hit and you fall down and your cleats don't catch. So I want to show you this injury right here. This is because I consult for the Oregon Ducks and try to keep them on the straight and narrow. And this was their highest. They got the #1, and this is not HIPAA stuff. This is in the domain of public knowledge. So this is all picked off the internet and so forth. But I can tell you, this is a Kayvon Thibodeau, and we'll show it again. And this is him standing there. They were playing some D2 team in the second game of the season, and he is felt to be going either #1 or #2 in the draft, and he's just standing there, and here he is, and then the guy rolls on him, you see right here in the 3rd frame, and then gets him. So let's watch the video again, and you'll see him get a high ankle sprain. Boom, that's it. And I consulted on him. All he had was an AITFL injury, and I said he'll be back in 3 weeks, but probably not before 3 weeks. And if you want to, cast him for a week and let him calm down, then really rehab him hard. And he was out in 3 weeks and came back. What was interesting was he was not there when the Ducks went back and played Ohio State. And even without this #1 player, they put Ohio State to bed on that game. They came back, though, obviously nicely in the rest of the season. So just back to a little bit of historical stuff, and this is Henry DeVries, who was Roger Mann's mentor, and he wrote the first surgery of the foot text in 1959. He was a podiatrist that then became a medical doctor. I was fortunate enough to meet him in the early days of my practice, and Roger Mann gave me such great support and so forth, and allowed me to be part of his textbook, which I helped edit with him and with Bob Anderson, with Charlie Saltzman at the end for 4 different editions, which was a great journey. And what's important is the large amount of information that you learn, and then you change what you advise. And what I've told you on high ankle sprains is what we know at this point, but I'm hoping that you guys will go out, and ladies will go out and learn more about this, and either prove me wrong or give us more insight into what is about here, because this is all about real injuries and people who are sometimes devastatingly injured and have career-ending injuries as well. I don't speak many languages. Mark probably speaks every one of these languages, and I'm unfortunately not very good at that. But so I've just had them translate the book into other languages, and it's great to just get this around the world to try to help to educate other people as well. So with that in mind, I came back to Boise, and I'm just sort of going full circle here. I have a ranch out in the Lost River where we have cattle and elk and deer and moose. But this is my dad at about 33. He's an orthopedic surgeon. This is me out in Hagerman. And here's 1 mile from that spot, now with me a little bigger at this point and a lot of greenheads that we were fortunate enough to knock down. And I don't suppose Evelina's here on this conference today, but I shoot with Evelina when we go to a meeting each year, and she's bad news. Do not go shooting with Evelina. She is a crack shot. Anyway, this is our family that we raised in Idaho with our little ones. We have another little grandson who's a great kid. And then fishing on the Big Wood River, just doing the things I like and enjoying life is where I'm at this point. But one of the things I really enjoy, and now circling back sort of in a very bipolar way to the NFL, what's really fun about this is that you get to meet people. And although this guy's kind of a weird dude, you get to meet every Heisman Trophy guy that comes through. And he had just put Oregon away for the national championship when I examined him, and I was examining his foot. There was nothing wrong with him. And he said, and somehow he knew I was from Oregon. He said, "Are you trying to hurt me?" And I said, maybe. And anyway, he was a good sport. But it's, the NFL is such a funny place to work for. They are so cheap. They make billions of dollars each year. And so I get, for all that study, I get an honor. I was getting an honorarium of $1,000 a year. And they came to me and said, "We're going to have to cut you to $750." And I go, wow, I don't know if I can handle that. I mean, that's, gosh, $250. I mean, so anyway, it's not about the money. It's about just the fun of doing it. And although it's drudgery, when you put all that stuff, as you all know, into the computer and you crunch it out and you go, wow, I didn't know that was right in front of me. As Bill Hamilton, talked to us, he was one of our founding mentors in the AOFAS. If you don't know what you're looking for, you won't see it. And when I talk to people, I say, well, I'm about ready to stop this NFL stuff. People want to buy the job from me. They go, "Could I pay you $10,000 to just come in your place?" And I go, well, it's not an auctionable item for this job here, but it is fun. So this is the dude that I showed you the high ankle sprain of, Kayvon Thibodeau, and he went through the combine. Again, these are not protected stuff. This is in the public domain, and he will be number probably 2 or 3 in the draft. He looks at me, he goes, "Do you want me to flex my muscles for this picture?" And I go, "Yeah, go ahead." And Mark, Ken, they know I'm a pretty big guy, but look at this guy. He's huge. And his high ankle sprain, life's just so funny. My wife is a huge Oregon fan, and she's watching him the rest of the season. I said, "I'm going to examine him." And she goes, "Mike, he's a step slower." And I said, "Really?" He goes, "Yeah, that high ankle sprain, he's just a step slower. He's not quite the same as he was." I didn't tell him that, of course. And this is Aiden Hutchins. So these are really great guys. He will be number 1 probably in the draft. He's like Joey Bossa, who played for Ohio State and went number 1. And this guy, they all got their degree. They're all working on their masters. This guy is a defensive end from Michigan, and you watch, he'll probably be number 1. So great guys. And these guys had no injuries. That's the other thing that's interesting. You'll see people have 10 injuries, and you'll see people have no injuries. And like McCutcheon, that played for Stanford, no injuries. He was on the punt return team and the kickoff return team. Some people just are genetically placed that they just don't get injuries, and they're lucky too. But this guy also had no injuries. So that brings me to the end of my discussion. We still got a few minutes for questions. The high ankle sprain continues on a little bit. We sort of have given them the bitter answer that we're going to try some braces and taping and spatting and see what that does. We'll continue to work on shoes and shoe interface. We're actually going to move on to Achilles tendon ruptures and just try to isolate that and see. There's a huge spike at the beginning of the season, and then a sort of a spike later on in the season. And we're going to try to see if there's conditioning or anything that can mitigate this. What's very interesting about that is that some of we call them outlaw studies, but they're people that want to do NFL studies. So they mine the internet, and then they go ahead and publish a paper on it. And we've seen lots of stuff. They don't have all the numbers by any means, but they're very clever. And what they use is they use the NFL fantasy football ratings for players to see how they're doing. And you got to know that Las Vegas gets it right most of the time, whether you're betting or whatever you're doing. You watch the point spreads, they're always correct. So they use NFL fantasy football player rates. If you have an Achilles tendon rupture and they rate you each year, you'll probably know without even touching that person if they're getting better or not. So there's always things to look out for. They're little clever things to learn from all kinds of papers that you see. And I'll stop at this point, Ken, and throw it back to you. How's that?
Mike, that was outstanding. Thank you so much. Man, that was a lot of information. What a cool experience also. So I just have a quick question, then I'll open it up to the group. You mentioned that you're able to give feedback to the players or to the teams about, hey, here are the safer cleats, or the ones less associated, or the ones that have, from your cleat work, lower risk profiles. I imagine there's some pushback primarily from shoe companies. Is it, as someone who takes care of a collegiate football team who doesn't beat Oregon very much, is there the possibility that information gets disseminated so that the safety profile in terms of high ankle sprains is known?
Well, the NFL is very proprietal with this information. As far as cleats are concerned, let me first answer that for the players. We give the players their information, but they can't choose a lot of things. They can't choose their jersey, they can't choose their pants, they can't choose their socks, but they can choose their helmet, their pads, and their shoes. Those are the three things. So they sometimes want to be individualistic. And now they've clamped down on helmets. They said you can't use your old high school helmet that you like very much. And it's surprising, Ken, that they do this. They from a shoe wear standpoint, we rate all these shoes, and they're rated on basically the amount of torque that they can sustain before they give way, both in forward, backwards, and with rotation as well. But it's, despite that, players will sometimes come, like they might buy their shoes at a Denver store that they went to in high school, and they still carry those shoes. And even though they're not even tested by us because they're archaic, but they love these shoes, and so that's what they wear. They have 10 pairs of those. So, but is this information available? Yes, I would tell you that as a treating physician for a team, that the people at UVA, that information is available, and I could connect you with them.
That'd be great. All right, other questions for Dr. Coughlin?
Mike, it's Robert Leland. I thoroughly enjoyed your talk. Thanks so much for coming. I would venture to say that indirect injuries in defensive players went down significantly after Barry Sanders retired. I loved your mention of the medial ankle, and I got my medial ankle fixed from Ken Lambert over 25 years ago. So, question: operative treatment of syndesmotic injuries, do all of those require deltoid ligament repairs? Yes or no, or some yes, some no?
I would say that's a great question. Thank you. I would say maybe, and I think that it has to be your index of suspicion. I think that they get imaged, but just examining the patient is going to tell you a lot. I mean, if they don't hurt there at all, I think that's something. If they're not swollen there at all, but if you have a question about it and you're doing a syndesmosis repair, it's not a terribly awful to put a small incision there and check it and fix it. I do also think I just came from a meeting with Rick Ferkel, and I just want to again stress, I was very much opposed to scoping ankles in the early days. We said, why scope all ankle fractures? And the data that he gives me on all the OCLs that he sees in the ankle joint with a fractured ankle is huge. And so I think that's something to be thinking about as well. It takes a little more time, but I think that that's an important point. But to your deltoid, I would say not always, but I think you have to have a high index of suspicion to look at it and maybe to do something.
Hey, Mike, it's Josh Metzel. Fantastic talk. I'm actually at the Broncos facility now, about to do physicals. So very, very good timing. The question I have for you is on return to play. And I'm sure you get the question frequently during the season, and as do we, about here's the MRI, the player's injured. When is he going to be ready to come back after an ankle sprain? So I was curious if you had an algorithm that you use. It's so difficult because I find that sometimes I think it's going to be 2 weeks and it's 6, and sometimes I think it's going to be 6 weeks and it's 2. So are you willing to give return to play estimates? I know Bob has moved away from it.
Yeah, Bob has totally moved away from Bob Anderson. He basically tells the trainer it's their deal, which is probably a good place for him, treating people from all around the country. And I would say with the 86 different injury patterns of the 110 injuries, it's all over the place. And when I saw Thibodeau's MRI, I knew he was 3 weeks because there wasn't anything else on the table. And so I could feel pretty confident with that. But as you get these other components, I think it's much tougher. And I think that Norm at Georgia has a really, or Alabama has a really good point. He's monitoring how active these people are after their injuries, and I think that that's one way that they won't tell you how active they are, but you can see how active they are with how many steps they're taking and the kind of things they're doing. So I do not have a great answer for that, but I do think your suspicion is really based on how much injury they've had. Thanks, Josh.
Dr. Coughlin, this is Dan Moon. Just a question. Early in your talk, you alluded a couple times to difficulties working with the Players Association. You mentioned that these injuries tend to be in the public domain. Is it mostly sensitivity from a privacy standpoint, or are they more sensitive due to implications for their contracts, or is it something more about potentially concern about the physicians in this case being more aligned with the owners versus the players? Because you'd think you guys have their interests at heart.
Well, Dan, thank you for that question. That's a great question. I would tell you that I don't really work for the owners. I really work there to try to help the players. I'm not sure they always know that, but I think it's all about money. And I think what the Players Association is worried that if we study Achilles ruptures, and we actually come with the conclusion that once you've had an Achilles rupture, you're 50% of the man you were before that injury. I'm just using that as an example. Some people come back and some people don't. But if you're making, like there was a receiver that was making $8 million a year, and he had an Achilles rupture, and Oakland signed him for $1 million a year. And you go, so he was 1/8 of the man he was before, I guess. But then he started getting better and he started coming back. And now I saw that he was making $5 or $6 million a year. So he obviously had more success. And so I do think they're afraid of the answer. And we've done some significant things, Dan, we've changed the pattern of the forefoot of the shoe, and we've reduced the turf toe injuries with our shoe wear sort of contribution substantially by stiffening the forepart of the shoe. Could we change the Achilles mechanism? I think we could. I think we could change the the incidence of ruptures if they will let us. And I think they're going to buy into this. It's very interesting. This peak in the early season is because of the fact that there are a lot of wannabes. They're either older players or players on the margin, or young players who are just trying to get into the NFL or stay in the NFL. And that thing spikes, that incidence spikes during training season for 3 or 4 weeks. Then it goes down. And then we have the second spike. It's not as high later on in the season. We don't know about that. And it may be if we could just have them do some extrinsic stretching or eccentric stretching and different things during the season, we might make a big difference. And we're basing this on the success of our hamstring study, where we're significantly affecting the incidence of hamstring injuries by what the trainers and therapists are doing. And I can't tell you specifically because I don't know. The hamstrings isn't my thing, but I can just tell you they're in hydration. I'm going seriously. So again, on Achilles, there may be a huge low-hanging fruit here that we have no idea about. And that's what having the power of this company called IQVIA, who crunch these huge numbers for us and say, well, have you thought about this? And we go, no, we never thought about that. So that's what's fun about medicine today, and with the ability to mine data, big data, it can sometimes make a difference.
Thank you.
Well, Mike, I want to say thank you again. That was fantastic. Really appreciate your being here, and that was incredibly insightful. So we really appreciate it.
Thank you, Ken. Mark, good to see you. Josh, good to see you. And Tommy, thanks for stepping in, and give my best to everybody there.